excited to be here.
We're very excited to have you.
Yeah.
So let me first give you a quick introduction. So it is a real pleasure for me to introduce our grand round speaker this morning, Dr. Sheetal Desai, who will give us a very interesting topic of grand rounds that you can see the headline for already on her first slide. So Dr. Desai got her MD degree in 2001 from the USC Keck School of Medicine. She went on to a fellowship in teaching and learning, which earned her a Master in Science in Medical Education in 2002. She then went on to a internship in internal medicine at UCLA, followed by a fellowship in rheumatology, also at UCLA, graduating in 2007. And she has taken some executive leadership training later on as well. So she became an assistant clinical professor at UC Irvine, where she still is to this day, in 2007. She was promoted to associate clinical professor in 2013, and then took on the program directorship for the Rheumatology Fellowship Program at UCI in 2012, and continued that for 10 years until pretty recently. In 2018, she became the interim chief of rheumatology and promoted to a full professor in 2022. And she has served from that same year, 22, as the DEI officer for the Department of Medicine. And just to give her even more work, she became the chief of rheumatology, and from this summer, last month, no, actually a little bit over a month ago, chair of medicine. So despite all of that, Dr. Desai has had a lot of time to garner honors and awards, a very long list. I'm not going to read them all, but she has Physician of Excellence awards from multiple years. She's gotten the Lucin Award for lupus clinical trials also multiple times over the last 10 years. She has published many papers, including ACR-EULAR guidelines for antiphospholipid syndrome. She's participated in crafting guidelines for lupus nephritis, and she has been very prominent in multiple societies, including those that advocate for women physicians, and she has published papers on skin color in rheumatology and many other interesting things. I'm going to hand it over to you, Dr. Desai, to take over from there and tell us about unmasking gender bias.
Yes, thank you. Very sweet. Thank you for going over the history. You actually helped me segue into the first slide, so I appreciate that. I am thrilled to be here to your esteemed group at the University of Washington. I will be delivering this talk on unmasking gender bias in the healthcare ecosystem. It is supported by the Association of Women in Rheumatology, and it was supported through the creation, was actually supported through an independent grant through Johnson & Johnson. This talk actually includes data from the American Medical Association, the AAMC, our very own American College of Rheumatology, the National Office of Pay and Equity, United Nations. I mean, many more sources that we will kind of go over, and I hope you find this interesting. And I'll share what really actually piqued my interest on women in medicine. I was in med school and graduated in 2001, like you heard earlier. And during the time I was in med school, about 40% of my medical school class and 40% of most medical school classes across the country were women. When I actually then went on to residency at UCLA, I had a lot of women in my residency class. When I entered fellowship at UCLA, Interestingly, 80% of our class in rheumatology fellowship, when we had about 8 fellows, were females. When I actually joined as an early career faculty at UCI, I was surrounded by a lot of women. When I stepped in as program director in 2012, nearly half of the program directors across our institution at UCI were women. It wasn't until I stepped in as interim chief in 2018 for our division of rheumatology that I was the only female chief out of 11 divisions in the Department of Medicine. And they had never had a female chief in the history of the Department of Medicine here at UCI. And in 2018, when I looked across our institution, I was the only woman in a chief or chair role across 24 departments, 20 clinical and 4 basic science departments across UCI Health. And that really piqued my interest because that was the first time I'd ever seen a sharp decline in women at a table I sat at. So that's really what piqued my interest early on, and I've continued to explore this throughout the years. Throughout this talk, I will focus initially on gender bias. I will then talk about the consequences of gender bias and where it comes from in our healthcare ecosystem. And then I will end with the most important part, which is how do we remove the mask of gender bias? So let's first start with gender bias. We all are exposed on a daily basis to so many more stimuli than we can actually process. And our brain relies on shortcuts to actually manage this information overload. Shortcuts to understand people are stereotypes, and gender bias is simply favoring one gender over another. It can be implicit or it can be explicit. So I'm going to start with this riddle. I first heard this riddle kind of back in the early 80s from Reader's Digest, for those of you that remember the Reader's Digest. And if you've heard it, please don't answer. I really want to leave it to the rest of your colleagues that may not have heard this riddle. So a father and son are in a car crash and they're rushed to the hospital. The father unfortunately dies. The boy is taken to the operating room and the surgeon says, I cannot operate on this boy because he is my son. Question is, how is this possible? And I'll quickly look at the chat. If those of you that have not heard this riddle, if you can maybe take a stab at what you think in the chat, that would be wonderful. I've just opened it up so I can see it. Okay, well, you guys are really good. I have mother from a couple of you. Several of you have said mother. So I want to let you know when I share this riddle, and when I have shared this riddle, it usually takes a while for people to think of that. And I've been lecturing now on gender bias since 2021. And you'd think everyone in my family would be able to answer this at a drop of a hat. So I asked this riddle to my almost 15-year-old son. And when I asked him this riddle one day at our dinner table, he kind of looked at me. It took him a while, and he finally answered grandfather. I asked my daughter, who's now a college student at Berkeley, and when I asked her this several months ago, she was stumped as well. And she finally said a priest because she assumed a priest would call this boy a son and that would work. My husband took him at least 15 minutes. He really was stumped. And finally, his answer was really embarrassing. It was a ghost. So I just want to let you know, yeah, 'cause I think I'm going through these slides a little too quickly. Where did it go? Hold on. I was just on that riddle, right? So I just want to let you know that he had no idea at all. And when I told them all it was a mother, that it was the mother, they all three of them thought, oh my God, that's obvious. They were trying to give me excuses for why that didn't actually come to their mind. But in the end of the day, it was their bias that they had when I used the word surgeon, that they really just did not think of a female being a surgeon. And after I gave them the answer, they said it was so obvious, but before they couldn't even think of it. So I want to highlight this study from the United Nations that was actually published in 2020. They looked at the Gender Social Norms Index. They looked at data from 75 countries across the world, which amassed about 80% of the world's population. And they found that about 90% of both men and women across the world have some type of gender bias against women. It was exactly 91% of men, and it was 86% of women that harbored some kind of gender bias when they looked at this gender social norms index that evaluated gender bias in beliefs that affected politics, work, and education. And when I actually heard this, I was so surprised, one, by how pervasive gender bias is across the entire world, but two, that women can be a source of gender bias just as much as men. Another study here, it was done by UN Women. It was a really interesting study where they wanted to actually evaluate bias that existed in the internet. And they looked at the Google autocomplete feature. And that really represents the most frequently typed in searches in Google. So it represents what people are thinking and what they're frequently typing in. When you actually do this and you type in men should, what you come across is men should be masculine, men should be strong, men should always pray, they should be what they seem. When you type in men should not, what came up was men should not wear skinny jeans, men should not cry, men should not show emotion, they shouldn't take paternity leave. When you type in men need women, they need space, they need to be masculine, they need to be tough, they need to provide. Well, now let's do the same search, but let's go ahead and change it and see what comes up in the autocomplete feature with Google when we do the same thing with women. When you type in women should, at least when we had done this a year or two ago, it said women should stay in the kitchen. Women should be, this is what came up as the autocomplete when all you type in is women should. They should be housewives, they should be mothers. When he typed in women should not, they should not be in combat, they should not be in politics, they should not vote, they should not be leaders, not breastfeed in public, not be paid equally. When you type in what do women need, what comes up as autocomplete is women need saving, they need a man, they need protection, they need to belong. So just giving you ideas of what exists out there with what are the most frequently typed in words on the internet. And now let's actually look at Amazon, very close to home for all of you, but our journey in artificial intelligence really begins with Amazon. They are a leader in using artificial intelligence in a lot of their business models. And when they were growing rapidly, and there was a huge need to hire tens of thousands of employees for Amazon, they actually tasked their engineers around the 2014 timeframe to see if the engineers can come up with an AI model to automate the hiring process so they can actually quickly hire people and to remove bias from the hiring process. Well, between 2014 and 2018, engineers had 500 attempts at actually creating an AI model to identify the best candidates based on their resumes. And by 2018, they had to actually scrap the entire program because what they actually created was the perfect model that actually was biased against women. This model, if there was anything on the resume that had to do with women, where a female had gone to an all-women's college, or a female was chief or a captain on a women's team, or they were on a women's chess club, this model immediately actually removed them from the pool to evaluate. So what about gender bias in AI? You have to realize, and Amazon was a leader in actually bringing it and evaluating it very early on. You got to realize that artificial intelligence models are trained on the mountains of data that we put in there that reflect our very own associations, our very own values, cultures, and our biases as well. And understanding that over 90% of the world actually harbors some type of gender bias against women, you can understand that bias is really an innate part of human existence, which means it's an innate part of AI existence as well. So something to be aware of as we all explore the interplay of artificial intelligence in our healthcare modeling systems. So women face a lot of invisible barriers to equality. And what barriers do women actually face in the workplace? Well, it was not that long ago that we actually had our first conceptual framework for gender bias that was actually put out in the literature. And that was by Dr. Amy Deal when she was at UPenn in 2020. She published this gender bias scale for women leaders. It has 47 items on this questionnaire. It's broken up into 6 different categories. And this questionnaire was evaluated and validated in over 1,600 women leaders that spanned law, spanned medicine, spanned higher education, and it spanned faith-based nonprofits. This questionnaire was also evaluated in the subset of women in healthcare in 293 women across US medical schools, and the data was published just recently in 2022. And I'm actually going to take you through that data when it comes to the women in healthcare. So this N of 293 actually evaluates the women faculty that participated in this study all across medical schools and was published in 2022. When they looked at Glass Cliff, and I just want to share the data with you, 32% of women across the US in medical schools had felt that they had been held responsible for organizational problems outside of their control. 13% of women in the organizations felt that they seemed to be given leadership roles with a high risk of failure. When it came to male culture, 57% of women felt that people in their organization assume that the top leaders will be men. 61% of our female faculty felt the decisions in their organization were made by men. And 49% of them felt that the boys' club mentality was still very much present in their workplace. When it came to constrained communication, this data was really disconcerting. 96% of women felt that they had to be mindful of their communication approach when they were exercising authority at work. 87% of women felt that they were cautious with self-promoting at work. 89% of women 89% of women felt that they had to downplay their accomplishments when they were speaking to others. When it came to unequal standards, 53% of women felt that their ideas were more likely to be taken seriously when a male colleague repeated them. 59% of women felt that they were really expected to be nurturing at work. And 70% of female faculty across US medical schools across our country felt that they had to work harder than their male colleagues for the same level of credibility. When you look at exclusion, about 63% of them did not feel welcome while attending social events with their male colleagues. 60% of them felt that their male colleagues socialized without them. When it came to mentoring, the lack of mentoring was very apparent, where 60% of women, because you have to use reverse logic, actually felt that they did not receive significant mentoring. And about 60% of women did not have a female mentor, and 66% of women felt that they had to kind of learn how to lead on their own. When it came to sponsorship, about half of women felt that they had another leader that actually sponsored them for a promotion. When it came to acknowledgement, it was very frequent that women felt 68% of the time that they were actually interrupted at work when they were actually speaking. 58% of women stated that they felt like they were taken for granted when they were helping their male colleagues with responsibilities. The salary inequity was pretty significant as well. 66% of women felt that they had made less money than their male counterparts, and 45% of women said they made not only less money, but less money than their male colleagues who held the same position as they did prior to them. So I just want to highlight with some of the data we saw across the US with female faculty revealed. And now I'm going to take you to one of the biggest databases on physician compensation. And if you're not familiar with Medscape compensation reports, I would urge you all to actually look at them. They have a lot of free data and free PowerPoint slides that they actually have online year by year. Medscape has been doing this anonymous self-reporting of physician compensation now for over 14 years. They have amassed data in over 100,000 physicians across the US in over 29 specialties, and they are hands down the largest and most comprehensive database when it comes to physician compensation. When I look specifically at rheumatology and I amassed data, I looked at pre-pandemic initially, and we amassed data from 2016 all the way to 2020 to evaluate what the difference in compensation was for full-time practicing rheumatologists across the country. You find that for every $1 a male rheumatologist makes, a female rheumatologist, when averaged out, made about 83 cents to a dollar. And so what does this actually mean when you're looking at the lifespan of working for female versus male rheumatologists? If you use an overall average of 40-year lifespan of working and lifelong earnings, that 83 cents to a dollar amasses to a differential of $1.8 million over the 40-year lifspan of work between a male and a female colleague in rheumatology. And that basically means when our female colleagues actually retire, they would have to work for an additional 8 years to make the same their male colleagues made in their entire lifespan. And I want to highlight this is not picking out just academic institutions. This is not picking out Kaiser databases. This is not just picking out private practices across the country. This is an amalgamation of data from all of these areas that were anonymously reported that actually came to that number of 83 cents to a dollar. When you're looking at primary care, it's closer to about 80 cents to a dollar. When you're looking at all specialties combined, it's actually closer to 70 to 75 cents to a dollar that our female colleagues make compared to a male colleague's dollar. So I just kind of wanted to take you back. And when I take you back a little further, I don't know how many of you are familiar with Equal Pay Day, but this was something that I really had not heard about until literally just about 2021 is the first time I'd actually heard of that. I don't know how many of you, if you could put in the chat, or if I could just kind of see a raise of hands, I don't know how many of you have heard of Equal Pay Day. Just open the chat, just to kind of see if anyone kind of, okay. So some may have heard of it, some may not have heard of it. So I just want to definitely, yes, Allison, definitely relevant for people of color. So I just want to highlight that because as a woman, I had never heard of this, and I can't expect my colleagues to have heard of it as well. So let's kind of take us back to 1963. In 1963, JFK had actually signed the Equal Pay Act, and that's when it went into effect. And in 1963, women at that time were making 59 cents to a male's dollar. And what the Equal Pay Act said is if women did something, worked in a similar area and did a similar type of work as their male colleagues, they should be paid the same. Well, fast forward now from 1963, let's take us into the 1990s. We had only come up to about 72 cents to a male's dollar, and we had not made a lot of progress. So the National Office of Pay and Equity, under the Department of Labor as well, decided to come up and enact Equal Pay Day. I'm starting to hear an echo. Okay, just let me know if you can't hear me as clearly. An echo is starting to come. So the first year that Equal Pay Day actually was announced was in 1996. And the spirit behind Equal Pay Days, they want to show how much longer a female has to work. So for example, this year in 2024, Equal Pay Day was March 12th. So that basically meant that women had to work all throughout 2023 and until March 12th of 2024 to make the same as their male colleague, their white non-Hispanic male colleague did. the year prior. Okay, so that's what Equal Pay Day means. Now we're starting to actually break it down further. In the beginning, it was just one pay day. Now it's broken down further into race, ethnicity, and even mothers versus fathers, which is very helpful to be able to see. So for this year, Equal Pay Day for Asian American and Pacific Islander women was April 3rd. So they had to, compared to their male colleagues, work all of 2023 and until April 3rd of 2024 to make the same as their white non-Hispanic male colleagues did last year. When you're looking at Black women, Equal Pay Day just recently passed July 9th. When you're looking at mothers compared to fathers, Equal Pay Day just passed August 7th. When you're actually looking at Latina women, they have not had the ability to even celebrate Equal Pay Day because they have to work all of 2023 and until October 23rd of 2024 to make the same as their male colleagues did in a similar line of work last year. And the group that comes in really at the very latest is Native American women, where Equal Pay Day is November 21st. So as of this year, so I kind of took you through the years. In 1963, women were making 59 cents to a dollar. By the 1990s, it came up to 72 cents to a dollar. Does anyone have an idea? Women in general in 2024 in the United States of America, how much do women in general make to a male colleague's dollar? Any idea in 2024? Just going to pull up the chat again so I could see if anyone has an idea. We have a guess of 80 cents. Any other guesses? You know, the reason I'm doing this is I'm just trying to compare and contrast what we have in medicine compared to the state of women just overall. So, great guesses. I want to share it's 84 cents this year. Last year, it was about 83 cents and some change. Just giving you an idea at the rate that we're actually improving, which is about a little less than half a cent a year. Women in this country will not actually receive equal pay until 2059. That basically means multiple generations of women have to actually deal with that. And 2059 is ridiculous when I think of my daughter who's in college at Berkeley, and I have to tell her that pretty much in the first decade or two of her career, she's probably not going to make the same as her male colleagues will. So I just want to give you an idea of how slow this is actually moving. And after COVID, we actually went a bit backwards. And that's what we're seeing all across the country. There's a gender inequality index that the United Nations has. And the number one country that's really actually bridged the gap of inequality to the 90th percentile is actually Iceland. And then it's followed by the Nordic countries. The United States, unfortunately, is number 42. So I just want to give everyone kind of a perspective on where we are. When you're looking at the European Union and the EU in general, their women there are at about 87, 88 cents to a male's dollar. So just kind of giving everyone an idea of what the state of women is kind of across the country, even outside of healthcare, and really across the world, and how far we actually have to go still to actually push for equality. So I just thought this was really interesting. And what we do here at UCI is on Equal Pay Day annually, I try to get all the women and our male colleagues across the institution to wear red to really signify Equal Pay Day and really signify how much in the red women are still in this era. So just really want to kind of highlight that. And I found that really fascinating. The date for Equal Pay Day for 2025, for example, usually is not released until about February. And it's because the Department of Labor really has to take all the data from the year prior, evaluate what it is before they put it out. So I just wanted to highlight this because I found it very fascinating, and sobering at the same time. So going back to this survey that Dr. Amy Deal had actually created and is available, and it's the only survey that has been validated in women in healthcare when it came to Queen Bee syndrome. And that's where women kind of protect their own turf. Remember, I said that 86% of women worldwide harbor some type of gender bias against women themselves. So women also are a source of gender bias. And when we look at these stats, 28% of women faculty across the US said women in higher positions have made their job difficult. 36% of women had said high-level women in their organization protect their turf. One of the saddest things is still harassment. According to the National Academy of Sciences, women across every stage of training, whether it's medical school, whether it's residency, whether it's actually as a faculty and in the workplace, women still have much higher rates of harassment and discrimination all across the board. And this came out in the survey that was actually published in 2022. 38% of women still said that they've experienced verbal abuse at work. 54% of women said that their behavior by their male coworkers had sometimes made them feel uncomfortable. 22% of women had still stated that they had been sexually harassed at work. Really sad numbers that in this era, we should not be having any tolerance of this at all. When it came to self-silencing, 65% of women said they speak up about challenges women face at work, which means 35% of women do not feel comfortable doing that. 59% of women advocate for women's rights at work, which still means 41% of women don't do it or don't feel comfortable doing it. Even when it comes to limiting your aspirations, 54% of women felt that they required a lot of encouragement for them to be able to accept a new opportunity. 49% of women felt that their personal obligations had prevented them from pursuing opportunities for advancement at work. So really, there were so many gender bias factors that came out in this validated survey of women in the workforce, specifically validated also in women in healthcare. And the gender bias factors that were actually experienced by more than 6 out of 10 women in healthcare was their communication approach, was downplaying their accomplishments, really being cautious with exercising self-promotion at work, feeling like they had to work harder than their male colleagues, feeling like they made less money than their male counterparts, and really still feeling like the boys' club mentality was still very much present at work. The men held most of the leadership positions and most of the decisions in their organizations really being made by men. So I just want to share some updated data on how gender bias is viewed by our female colleagues across the United States in medical institutions. Now that we've heard that gender bias is really pervasive all across the world, and then we've heard that our female colleagues all across US medical schools have felt similar types of gender bias actually in their workplace. We want to understand where in the healthcare ecosystem does this gender bias actually come from? And I want to highlight that it can actually come in your very own backyard. Just like I said, that nearly 90% of the world's population harbors some type of gender bias. I'm just going to follow the time against women. Got to be aware that that can be in your own very practice, whether it's your physicians, colleagues, whether it's your APPs, your nurses, your MAs, or even your administrators. In a study done by the American Medical Association, looking at senior female physicians who actually looked back on the early stage of their career, more than 3 out of 4 of them said that they had experienced gender discrimination in their workplace. And about half of them had said that they had experienced sexual harassment, professional isolation, and salary inequity. And you can imagine that the consequences of feeling this gender bias or noticing this gender bias really can result in their abilities being underestimated, females being assigned mundane tasks, feeling excluded or marginalized, having unequal promotion opportunities, and really feeling a bias against pregnancy and childcare related issues that actually come up. Now, when it comes to patient care has gotten so complex where it's got like the era where we only interacted with patients really live and face-to-face has now been expanded to email communication, EMR communication, telephone communication, video communication. And patients can also be a source of gender bias as well. And so a huge study that was actually carried out at Stanford in 2020, where they actually surveyed all of their physicians, and they had about 1,400 physicians that had filled out the survey. And they asked about sexual harassment, verbal abuse, and mistreatment, and hands down, females compared to their male colleagues had significantly higher rates of sexual harassment, sexual abuse, or verbal mistreatment. And that was definitely significant. And when they actually broke it down and looked at where was this coming from, 71% came from patients, 30% from colleagues, 13% from leadership, and then other staff and nurses. And it really blew my mind when I saw this really high percentage from patients. And then when I looked at when this survey was actually carried out, which was about September through November, I think, of 2020, it made a lot of sense because it was right the first year when COVID actually hit all of our institutions across the country and really became a source of contention and a lot of stress, especially for patients. But I just want to highlight how much actually came from patients in this survey. And now when you're actually looking at patient satisfaction scores, think about Press Ganey, for example. It's really being used now as a metric for quality in a lot of our organizations across the country and evaluated by CMS as well. There are studies after study coming out, and one study particular done at Stanford looking at a gynecology practice and looking at their Press Ganey surveys between men and women physicians in the gynecologic practice. They found that female gynecologists were 47% less likely to actually get top scores on Press Ganey. When you're actually looking at online reviews, and in a study looking at over 154,000 online reviews in Google on physicians, females were more likely to have negative online reviews compared to men. When you're looking at gender stereotyping, happens to us all the time. When we walk into a room, that it's often assumed if I walk in, I was just on inpatient last week for rheumatology. It's often assumed when I walk in with a male on my team that I'm not the physician in charge, that the male on my team, whether they're a fellow or a student, they are often viewed as the actual person in charge. So just want to give you an idea of how prevalent bias is from patients as well. Now, when we're looking at institutions in academia, you'd think that we would be immune from gender bias. You'd think that we, being academic institutions, being at the forefront of actually medical education, training the next generation of physicians and engaging in biomedical research, that you'd think we would exemplify what equality and equity actually is across all of our institutions. And I want to share that we are not immune from this. And I will share data specifically in academic rheumatology that was just published by April Jorge in 2021. So if you're actually looking at gender disparities in academic rheumatology, they looked at all rheumatologists across the country, and then they looked at the 941 rheumatologists that were specifically in academia. And what you found is females made up a majority of instructor and assistant professor positions, but they made up a minority of associate professors and significant minority of full professors. When you look at the average age of females and males in academia, there was about a decade differential in the age. And when you were looking at division director roles, which are academic chiefs of rheumatology, and program director roles, there was still actually a differential. And now if you step back and you look at data from the double AMC, I'm going to compare and contrast stats from 2019 to 2023, but I just kind of want to show you 2019. So 2017 is about when women achieved parity in medical school admissions compared to men. And it was about 2019 that women took over as medical students in men compared to men. So over 50% of medical students from 2019 onwards were actually female. And just to give you an idea of UCI this year, we're at 68% female in our current incoming medical school class. So just to give you an idea of how much this is actually increasing over the years. In 2019, physicians in training made up about 46% were female. Females made up greater than 33% of the workforce, 38% of faculty. Yet despite these statistics, they made up only a quarter of full professors across medicine, 18% of department chairs, 17% of deans. And now fast forwarding to the most recent stats we have in 2023, women make up 47% of all positions in training, greater than 37% of the workforce, 44% of medical school faculty. We've come up a little bit for full professorships at 29%. We're at about a quarter of department chairs. We've come up significantly in dean positions. We're at 27% of deans across the country. So I just want to compare and contrast not just data in rheumatology, but data across medicine as well. And so now if we look at our professional organizations and guidelines, and if you just look at your proportion of female speakers, this was a publication looking at female speakers from our very own American College of Rheumatology in 2017, you can see that females made up a majority of the general sessions and the RHP. They made up, a majority of the study group, but when it came to abstract, pre-meeting, and more of the pivotal sessions that people vie for, the ACR general sessions, the meet the professor sessions, the workshops, women made up a minority of speakers in all of those areas. And this was a time where women made up 46% of all active rheumatologists in 2017 were women. So I just want to highlight that we got to ensure that we have appropriate representation of women in areas of leadership all across multiple facets of medicine, including our very own professional organizations. And we need to ensure that it really matches the proportion of women in our fields that are actually practicing. When it comes to research in public health, sadly, we see the same thing. When it comes to female rheumatologists, they have half as many publications, they have half as many grants when it comes to NIH grants, and we see this across the board in medicine. When it comes to clinical trials, there's been gender blindness that we've actually seen in clinical trials where because of the thalidomide experience that we had in the 70s, women were actually taken out of clinical trials from 1977 until NIH actually had passed the Revitalization Act in the early 1990s. And when it came to animal studies, female animals were only really pushed and used in the most recent years. So I just want to give you an idea of how much gender blindness exists in clinical research and how women still don't achieve parity in academia when it comes to research endeavors. So when you're looking at publications, and this is from April Jorge's article that was published looking at the 941 academic rheumatologists. At one time frame, they found that female rheumatologists had 53% fewer publications than their male colleagues. They were less likely to have the pivotal positions of first or last author. And then when it came to NIH grants, they were definitely less likely, about 50% less likely to actually have grants and to have any grants at all, 43% less likely. Where we achieved some parity was actually in clinical trials. So really, I just hope that I've kind of given you a quick overview of gender bias, not just in the world, not just in the United States, in healthcare as well, and where in the healthcare ecosystem women may actually face gender bias can be in your very own backyard in clinical practice, can definitely come from patients is what was seen from our Stanford studies and Press-Ganey studies, can come from, and be perpetuated and still exist in our institutions and academia, still exist in our professional organizations. And unfortunately, we have not achieved equity when it comes to research and public health. So you can imagine that the explicit bias, although we've seen a decrease in explicit bias against women, it sadly still exists, with women still reporting it across medicine, but implicit bias very much exists. And this actually can create many inequities in the workplace, which really results in stress, in decreased overall well-being of our female colleagues, decreased job satisfaction, a decreased sense of belonging, decreased professional fulfillment, and higher rates of burnout and a higher intention of leaving. And the 1 to 2 million women that have left the workforce since COVID in 2020 that really abruptly left the workforce for a multitude of etiologies where caretaking needs was the primary one. We have still not been able to rebound from that. And we are 4 years out from when that, 4 to 5 years out from when that first occurred. So I just really want to share kind of the ecosystem of bias when it actually comes to women. And now in the last about 10 minutes or so, I'm going to actually talk about what we can do to remove the mask of gender bias. And I'm hoping to leave a little bit of time at the end for discussion. So a lot of people think that all you got to do is just add women and stir and bias will be gone. And I actually thought this picture was a really cute picture depicting that. And it's not as easy as adding women. So just to give you an idea, does anyone know when women actually surpassed men in college admissions? Any idea? So now I'm just talking in undergraduate college admissions. Do you know when women actually surpassed men in admissions? Because it wasn't that recent at all. And I was surprised. I only learned this actually just maybe 2 years ago. Yeah, you'd think maybe mid-90s. I mean, I would have thought about that just thinking of my own experience. It was 1979 was the first year, 1979, that women surpassed men in college admissions. And it has only increased ever since then. So currently women make up 70% of valedictorians in high school across the country. Women have surpassed men since 1979 in college admissions. There are more women in trade schools, in vocational schools, in colleges. There are more women doing masters, more women doing professional degrees than men overall in every sector in education and higher education. And despite that, less than 10% of our Fortune 500 CEOs are women. In every sector you look at across our economy, and sadly, even our world, women, despite making up the majority, still have not removed gender bias. So I just want to highlight that and just kind of share some of those statistics. So really adding more women does not solve the problem. And it doesn't solve the problem because it doesn't change the organizational systems and structures that were created in an era where there were not a lot of women in that place. And they have not actually been evaluated and changed to accommodate for the needs of actually having women in the workforce. So step one in evaluating gender bias is really just acknowledging it, acknowledging that we all have it. I, as a woman, carry it, and all of our colleagues will have it. Everyone across the country will have it, and up to 90% of our world's population actually harbors gender bias against women. So we need to really normalize how pervasive gender bias is. And it's not that someone is bad if they actually harbor it. Explicit bias has decreased, but there's so much implicit bias that we are not aware of as individuals, as a community, and as a society. And then the next thing is you really need to measure gender bias. It's one thing to be aware of gender bias, but how can you effectively change something if you're unable to measure it, if you're unable to quantify it, if you're unable to understand it within your organization? And now we actually have a conceptual framework for gender bias in healthcare. It's the only tool that we have that's available and has been validated for women faculty across healthcare. And so I would urge you all to look into this, to evaluate this. This is something that now, in my role as chair of medicine, I will actually be sharing the survey. About 49 point something percent of all of our faculty in the Department of Medicine are female. And so I plan on first starting with having our entire Department of Medicine actually having all the women take the survey so I can evaluate what are the thoughts, perceptions, and experiences that women here in UCI actually have in our department, right? And once you understand where you exist and what the biases are in your organization, only then can you actually plot your course where you want to provide education, help establish equitable policies, facilitate mentorship and sponsorship, and then at the end, you have to enforce accountability. So education awareness is key. Like I said, people need to be aware that gender bias is very normal, and there are fun ways of actually evaluating gender bias. Across the UC system, we have, if you're in any managerial role at all, whether it's administrative, whether it's a program director, whether it's as a division director, a chair, annually you have to undergo these implicit bias training. I'll tell you that I don't think the data shows that implicit bias training is the most effective. There are so many ways to actually get training. Bystander intervention is one of the better ways, but there are fun ways of doing it. If people love reading books, Blink by Malcolm Gladwell is an excellent book at normalizing some of these things. If any of you have heard of the Harvard Implicit Bias Association test, it's a huge project, implicit bias, that was started by the Harvard Psychiatry Group, and they've had free association tests on their website now since 2011. And then I think there are about 19 of them, and they're really fun to do. They're really eye-opening. They will review gender. They'll review bias with women in science. They'll review bias with religion. I mean, there's so many different categories, and they try to evaluate how quickly you will make an association between two words compared to another pair of words. So they'll combine women and engineer, and they'll see how quickly you will click on that association compared to a male in engineering. And it's actually quite eye-opening. And I've actually had my teenager kids do it as well, because sometimes you don't realize the biases that if someone asked you, you would say, I absolutely do not have. But implicitly, because of how we've been socialized, because of the television shows we watched growing up, because the magazines I read growing up, because the social media everyone is exposed to, and our younger generations from Millennial Y to Gen Z that they've actually had a lot more exposure to, there are so many biases that are fed to them. So just talking about just different ways you can explore evaluating gender bias. And then once you do, you need to make sure you evaluate and establish equitable policies. So all of our search committees, whether it's a search for a division chief for rheumatology or nephrology or endocrinology, all of them have to have women on the search committees. But what I realized is there's no clarity on the number of women. So for example, for a rheumatology search committee that we did about 4 to 5 years ago, there were only 2 women on the search committee of 12 individuals for evaluating a division chief in rheumatology at a time where women made up about 48% of the rheumatology workforce. So you really need to make sure that when you're actually creating these meetings, it is really equitable and representative of the percentages of women that you actually have in the positions that you're evaluating. We need to make sure that our processes for promotion and hiring are open, they're transparent, and they're equitable. We don't want to be making decisions and choosing people on the golf course or in areas where everyone doesn't actually have a seat at the table. As I stepped into the chair role, I've tried to make sure we've had consistent scheduling of meetings. I don't like the death by meetings, and I try to make sure if I'm doing a meeting for all of our department faculty, it's transparent, it's to the point, it is quick, and usually our meetings have lasted, I think my first one lasted about 15 minutes, the last one lasted about 22 minutes, but if I'm taking people's times in the evenings, I need to make sure there's a reason to have the meetings, consistently stay with scheduling, start on time, end as early as possible. And if it's not worth having it in a meeting, I will send it out as an email. And then last but not least, parental leave policies. And I want to focus on that a bit. Work-life balance is so important. Culture of our organizations really help the women in our organizations. And University of Michigan has had an intern study that's been an NIH-funded longitudinal study that they've had for close to a decade, where they follow interns and they enroll interns into the study all across the country, and they follow them annually even after they finish and they graduate. And a sobering fact that they found is looking at interns that had already graduated and are now 6 years out, men and women. When they looked at them 6 years out and they were evaluating them in the workplace, they found that 2 out of 5 women left medicine or went part-time, compared to 3.6% of men 6 years out of training. This was really disconcerting to find such significant differences in the amount of women leaving medicine compared to men. And the number one reason was childcare and caretaker needs. And this was a quote taken from their publication, which really kind of resonated and really stuck with me, is when as a woman you invest more than a decade of your life to learn a skill and you're willing to walk away from that so early in your career, it's more than a red flag. It really is a burning fire. So when it comes to work-life balance, because of the ages that women are, by the time they finish medical school, by the time they're in training, and by the time they embark on a career, there needs to be more support that actually is given to women to help minimize their feeling of having to compromise career advancement for life balance. And then they have to choose one or the other. And it's ensuring we have family leave and flexible work options, not just for the women, but for men as well. Availability of childcare, that's a number one reason. About 18 years ago, I would actually cancel my clinics at least once a month when my kids started going through daycare because they were sick, and I would then get sick and I would have to stay home and take care of them. But really quickly in 2020, we had the availability of childcare started overnight in a lot of our healthcare institutions across the country to bring women back into the workforce. And here we are 4 years later, and that is now gone again. So I just want to highlight that, and something that I've worked on. And I've been a huge proponent, and UCI is now the 5th institution in the country to offer this amongst the academic institutions, is providing lactation financial credit. Because as our women come back and they try to breastfeed and they take time out of their clinic, and I block them for 30 minutes in the morning clinic, 30 minutes in the afternoon clinic, an hour a day, 5 days a week, 40-something weeks out of the year, they lose 200 plus hours of RVU generation. And it is not okay for women to take time off for pregnancy and childbearing and their salary to go down, for them to come back and to follow ACOG and the AAP recommendations on lactation, which is now 2 years out because of the benefit to women and children, and not be able to do that because of the lack of time or the financial hit that they have to take in order to be able to do that. So there was a publication from my colleague at UCSF last year that showed that only 4 of the top 50 US medical schools offered lactation financial credit. And that actually served as my nidus to get that approved at UCI, which we were fortunately able to get approved as of July 1st of this academic year. So super proud of that. If anyone's interested in talking about that, I'd be happy to share, because it really saddens me that in 2024, there are only 5 academic institutions that offer this across the entire institution. Mentorship and sponsorship. I want to highlight that women are traditionally over-mentored and under-sponsored. So a mentor is someone that has the knowledge, that shares it with you, but a sponsor is someone who has power, that uses their power for you to pull you into positions. So it's so important to make sure that our female colleagues have a formal pathway for their career trajectory, have a formal mentorship program. Something I'm creating in our Department of Medicine is to make sure, in addition to their chief being a mentor, they have an identified female mentor they can reach out to as well. All right. And I would be amiss if I didn't share that men are our mentors, men are our sponsors, and they're our champions. If I was not aware of this level of gender bias in even our academic institutions until 2018, when I began actually researching this and really looking around and evaluating this, I can expect our male colleagues to be aware. But I would hope that once they're aware of this, that we can work as allies to help bring equity and equality to healthcare, which is what we should actually be promoting, especially in all of our academic institutions. And I'll say my top sponsors currently are men. It's the dean that sponsored me to actually enter this role as chair of medicine. So really, men are our biggest advocates. They're our sponsors. I really share this data not to highlight that men are bad and women are better, but to share that we are all biased against women. There's a lot of bias that still exists, and how we can actually all work together to eliminate some of this bias, because I don't think it's reasonable to think that we got to wait till 2059 to actually get equity. And when it comes to gender inequality across the world, currently it's anticipated another 250 years until all countries actually reach gender equality, and that is not tenable in this era. So really, once you're able to evaluate and then enact these processes, you really need to create a safe environment for culture change and hold people accountable and have safe reporting mechanisms if something has been identified. So I want to just give an overview. Gender bias is pervasive in our entire world, in our country, and unfortunately in the entire healthcare ecosystem. We want to disrupt the gender bias cycle by acknowledging it, by measuring it. You can use the gender bias framework that I shared with you by Dr. Amy Deal. And then only once you measure it can you actually work on correcting it. And I'd be amiss if I didn't actually clarify that all the data I shared is based on traditional roles of gender of men and women. The intersectionality of race and ethnicity is still, and gender is still being evaluated further. And the amount of data that we have on that is still much smaller than the amount of data we have on the traditional roles of men and women. But I want to share, as we saw with Equal Pay Day, as we start sparsing it out further and breaking it up by race, ethnicity, and gender, what we see with women is only going to be worse when you break it up. And then just kind of sharing my journey, I stepped in as interim chair, as interim chief. I was program director at the time. I had a hard time actually finding people in my institution that really understood what I was going through and like-minded. So in 2020, I joined the Association of Women in Rheumatology. I've been lecturing on this both locally and nationally, really to increase awareness, because I feel like if I'd heard this back when I was in college, if I'd heard this back when I was in med school, if I'd heard this as an early career faculty member, I think the way I would have approached things would have been really different much earlier on. I stepped into the professor in chief role in 2022. That's when I became the DEI officer for our department. I took part in this executive leadership and healthcare program that Drexel has, which was excellent. And I did this last year. And July 1st, I just stepped into my interim role as chair of medicine. And in this role, I'm going to be putting out the gender bias scale in the coming month for all of our women leaders in the Department of Medicine. I'm in the process of establishing a women's committee so I can evaluate metrics for advancement, for acceleration, for mentorship, sponsorship for our women in the Department of Medicine, and create mentorship pathways and provide even more leadership and networking opportunities that complement other programs we already have across UCI Health. You can never have enough programs. The more opportunities that are available, the more people and women hear about this. And I will go ahead and end there. I know I brought us right to the hour. I apologize. I could talk about this for hours and hours, but I will stop and open it up if there's any time for questions. I'm going to go ahead and open the chat function.
So
Thank you
thank you
all.
very much, Dr. Desai, for really thought-provoking and interesting presentation. And yes, if anybody has a question, just please unmute yourself and ask.
I'm just looking through just to make sure. Elizabeth had asked if we have follow-up data from the ACR. You know, I haven't seen it. I'm going to have to look, but God, it was such a great, a lot of these studies are so great that I think they need to be repeated, just like the study that was done looking at physician or patient morbidity and mortality and 30-day readmission rates for patients under Medicare all across the country. That was done by our Harvard group and then redone, and the data was the exact same. So I know that Danielle is going to help. If any of you would help with setting up one-on-one talks, if any of you are interested in setting up a Zoom and doing a one-on-one, I'd be more than happy. I just couldn't do it today because I'm in the middle of lupus clinic. But if, as the week goes on, if you just want to email Danielle, she'll email me. We'll be able to put something on the schedule in the coming weeks because I would love to spread the knowledge, collaborate, and also hear about the wonderful things you all are probably doing at University of Washington. Okay. I will end here. Thank you all, and I hope everyone has a wonderful week.
I have a quick question. Sorry.
Week. Oh, no, go ahead. Go ahead, Nadine.
I wasn't talking. Thank you so much for the talk. It's great. You mentioned earlier that if you knew what you know now earlier, you would have done things differently. I'm just curious, for those of us who are early in their career, what would you have done differently?
So I'll tell you, I tell people that I have the triple threat, not the kind of triple threat you think of in academia, but I'm Gen X, I am a female, and I'm Asian. So I had a lot of respect for authority. I felt, and my husband would bug me all the time. He'd say, Sheetal, I don't think you're progressing at the rate that you deserve to progress. I think you need to go up for an accelerated merit. I think you need to do this. And for years, I would tell him, look, I'm in academia. It is completely fair. When my chair thinks I'm ready for a promotion, they'll let me know. And so really, I don't think I was aware of this. And it's not that they were holding me back. I just think there's a lot of gender bias with this. So for example, had I known about this early on in medical training and medical school, I think I would have asked a lot more questions. I think I would have paid attention to our tenure track a lot more. I think I would have been more aware. It wasn't until 4 or 5 years ago when I had to sit down and make a list of mentors and sponsors. First, I didn't even understand the difference that mentors will have knowledge and share it with you, but a sponsor has power and will actually use it for me. I had a whole bunch of mentors. I had 0 sponsors on my list that I had to create as of 4 to 5 years ago. And I had to spend the last couple of years actively seeking out and aligning with sponsors that really aligned with my mission. So just letting you know, I think if I entered in understanding the state of women in general, I think I would have asked more, I would have been more aware, and I would have pushed the envelope more. And I'm happy with where I am and what I'm doing. I just feel like my trajectory, if it's here, it could have been pushed up a bit more. And so that's the whole point of this lecture series, is really to go out. I do it for divisions of rheumatology. I do it for departments of medicines. I've done it at medical schools. It's really to hit women at all levels of their career so we can all work collaboratively with allyship with our colleagues to be able to push this forward. All right, that helps.
Excellent. Thank you so much. Yes, it does.
Of course. Look forward to talking to some of you. And again, I wish you all a wonderful week, and apologies for going over a couple of minutes.
Thank you very, very much.
Of course. Okay, take care, everybody.
Bye.
Bye.